On behalf of Jacksonville Pharmaceuticals Limited, makers of Lycorate soft gels to manage the oxidative stress during fertility treatment, say no to anemia with JP-tone iron syrup and natural micronized progesterone sustained release oral tablets as Divagest SR 200 and 300 mg. I'm Dr. Vipin Tyagi along with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena. We welcome and thank Norjon Royal College of Obs and Gynae for organizing this fertility conclave with Jacksonville as academic partner. Welcome to all the esteemed faculty present with us today. A warm welcome to all the attendees. Please post your queries by text in the Q&A box to be answered at the end. Please note this webinar is streaming on Facebook Live. The recording will remain on Jacksonville's YouTube channel for reference and promotion. I will now request Dr. Sweta Gupta to kindly initiate the session.
Thank you, Dr. Vipin. I am Dr. Sweta, and on behalf of RCOG North Zone, I welcome you all for today's webinar. Keeping up with RCOG's initiative, educational initiative, today's webinar is from reproductive medicine specialty. And I'm really thankful to our chairperson, Dr. Ranjana ma'am, for always guiding us, encouraging us, and giving us opportunity to have this seminar today. And I would now request Dr. Ranjana ma'am to say a few words. Ma'am, over to you.
Good afternoon, everybody. So on behalf of AICC RCOG North Zone, I welcome you all to this webinar on two very important topics in subfertility management. Random start controlled ovarian stimulation. That means starting stimulation regardless of the day of the menstrual cycle. And the second session, a panel discussion on the clinician's perspective on egg freezing. As the limited evidence gathered so far shows that the random start ovarian stimulation has outcome similar to conventional early follicular phase start, which seems to be a significant advantage in terms of decreasing total time for an IVF cycle, especially in urgent situations like fertility preservation in patients waiting for their oncology treatment. For the talk on the topic, Dr. Sweta has managed to bring to us a researcher and an expert in the field of fertility medicine, Dr. Anil Gudi. We are privileged to have him here to get a detailed insight into the subject. For the panel discussion, we are honored to have the experts in the field to deliberate on egg freezing. I welcome once again our AICC RCOG Chair, Dr. Bhaskar, our foreign faculty, Dr. Anil Gudi, Dr. Shantanu Acharya, all the chairpersons and the panelists, and I welcome you, the delegates, and hope you enjoy the learning today. Now I hand over to Sweta to proceed.
Thank you, ma'am. For the first session, we have Chairperson, Dr. Ranjana Sharma. She is also consultant at Indraprasth Apollo Hospital, New Delhi. Next, we have very dynamic and versatile chairperson for AICC RCOG, Dr. Bhaskar Pal. He is senior consultant gynecologist at Apollo Hospital, Kolkata. He is also past vice president of FOXI. Next is our very Dr. Sohani ma'am. She is very hardworking and inspiring, multifaceted. She has been our chairperson for AICC RCOG North Zone from 2012 to 2017. And presently, she is also senior consultant Obs and Gynae at Indraprasth Apollo Hospital, Delhi. Next, we have very dynamic Dr. Sarita Bhalerao. She is chairperson AICC RCOG West Zone. She is also president of MOX, and she is working as a senior consultant Obs and Gynae at Breach Candy Hospital and Bhatia and Wadia Maternity Hospital, Mumbai. So over to you, chairpersons, for this very session.
Thank you, RCOG North Zone, and especially Dr. Ranjana Sharma for inviting me to chair this program. And it's an absolute pleasure to introduce my very good friend, Dr. Anil Gudi. Anil and I know each other from our days in Mumbai in early 90s and also late 90s and early 2000s when we worked together at several hospitals in UK. Dr. Gudi is a consultant in reproductive medicine and ART at the Homerton Fertility Center and Fertility Plus London. He specializes in assisted conception techniques, fertility preserving, keyhole surgeries, endometriosis, and all aspects of fertility treatments. He carried out extensive research in Bombay Hospital in India and Homerton Hospital in UK. He's demonstrated new challenging techniques in treating women with multiple failed cycles, genetic screening of embryos, and pregnancies to egg freezing. He's been instrumental in introducing new stimulation protocol and tailoring treatment specific to each patient. And Dr. Gudi not only runs online teaching fertility course, but he started fellowships where people who train partially at the Homerton and partially at a center in India. And he's taken great efforts to train people in ART. Over to you, Dr. Gudi, to speak on random stimulation.
Dear Bhaskar, thank you very much for that introduction. I think that was very kind of you, and we go a very long way. And I think first and foremost, I would say thank you to Sweta. Sweta worked with us a long time ago, and thanks to her, I'm talking here. And thank you, Dr. Sharma, for chairing the session. So the reason I suggested random stimulation is because it's one of my interests, and I think it comes up from a bit of history. On the NHS, many of the NHS centers have a cutoff for AMH while offering IVF. And in my area, almost all the CCGs, which are funding bodies, restricted at AMH of less than 5.4, and they put into it constraints of antral follicle count. So I believe a lot of young women are unfairly denied the chance to have IVF by being told that they have no other choice but to go for egg donation. And many of these, in a year, I would say generally about 20 or 30 of these would come and see me in my private sector saying, well, if I can't have IVF, should I have egg donation? And I think I've always believed that egg donation is a challenge, and I think it's the onus and the burden of I'll say, of life and of treatment is carried almost always by the woman in egg donation. So I said, well, why don't we try something different? And over the years, I think it forms almost half of my private practice in the UK of seeing women with very low AMH. And I feel that if the women are young, I don't think it makes any difference what their AMH is. And that's my conclusion after having done about 10 years of treating poor responders. And I'll bring some of my concepts. They can be challenged because they are very challenging. Very few people do that in the UK. But I think it's worth looking at. Much of these concepts have come from how the ovary responds. And over the last review, and we're trying to publish it, we still managed to achieve a live birth rate of around 30% in women whose AMH was less than 3.2 pmol. So let me go ahead and say, the reason I'll say, let me start with poor responders is because you can do random start on any oncology patient. But in poor responders, I'll be able to explain what a random start means and how we can evolve stimulation protocols which look towards giving the woman the best chance to achieve a pregnancy. Now, the reason why we look towards poor responders is that we've tried everything, including prayer, to try and improve the results. And there are multiple studies. And if you try and look at the evidence is with multiple trials, multiple meta-analysis, and we don't have a right answer. Now, there are only two treatments, 100% treatments for poor responders. And one is, I always say, it's adoption. Adoption has a 100% success rate, unless you're completely bonkers, where the law would allow you. And the second is lowering female age is also another way of treating poor responders. And in fact, you can't do that. So we are left with looking at how the ovary responds. Now, the next question is that, can you stimulate women at any time of the cycle? And that's exactly what random stimulation is. So before going to this, we'll say, let's try and understand the physiology of follicular recruitment. And if you can, and I always tell my trainees, if you can understand what the ovary is trying to tell you. So in simple terms, I say, can you listen to the ovary? The ovary will tell you its story, and which means have the patience to do an ultrasound scan. And in large units, it doesn't happen. So if you see my NHS center, we see close to 3,000 patients, and we do about 1,000 IVF cycles. And in those cases, trying to understand what the ovary does is an impossible task. In a private sector, which is much smaller, these questions can be answered. So let's try and understand what we know from research done in the 70s and 80s. So follicles go through various stages of recruitment. One is a gonadotrophin independent state, and those are primary follicles, primordial follicles, and those very much, you can't do much about them. Each day, about 30 primordial follicles are recruited into the growing pool. They're pituitary independent, except in cases of long-standing primary hypohypogs. How follicles are initiated or activated is really not known, and I think we still are trying to understand these pathways. And in fact, from a medical point of view, you cannot manipulate this pathway since drugs do not work there. So from the first stage, we'll say, what is the take-home message? And we'll say AMH is not a marker for primordial pool. And thus, when you give chemotherapy that depletes number of growing follicles, but spares the primordial pool, it involves a decline and recovery of AMH. And in fact, that is something which we haven't yet understood very well. Now, what is more important is the gonadotrophin's sensitive stage. And this is a stage when we look at your secondary follicles and the antral follicles. And this is here that we can start understanding what the woman's ovaries start doing. Now, follicles that go between 3 to 5 millimeter become dependent on a gonadotrophins. And what research tells us is that FSH-LH receptors start being detected. And in fact, what we also know that this varies, and as women get older, many of these small follicles may see fewer FSH and LH receptors, so its recruitment is relatively less. So it is these follicles at that size which are more likely to react to stimulation. And so if you decide I want to give a prolonged downregulation, and which happens in some endometriosis protocols, or you give the pill for a long time, we know that the follicles become smaller, but we also know that gonadotrophins are required for a much longer duration of stimulation. So now, and this again was studies done in literally the 80s, and what they did is they scanned women at regular intervals throughout their cycle. And what I have observed is that follicles emerge as 3 to 5 millimeter antral follicles and are seen on a scan. So what researchers did is they said, well, how does this recruitment occur? And this recruitment occurs of follicles that can be seen on a scan occurs in 3 different ways. One, it's probably a continuous recruitment. Second, it's a single recruitment episode. And third, are follicular waves. Now, do women do that all the time? And I don't know that. I really don't know whether women differ, or do they come into combination of factors. Now, in the continuous recruitment, what we know is that small antral follicles, 4 to 6 millimeter, are recruited continuously. And the follicle destined to ovulate is selected by chance from a continuous supply of antral follicles responding to a rise of FSH. Now, which is fascinating, which basically means that, in fact, competent follicles are produced all the time. And in fact, it is not that the leading follicle is the most competent follicle in terms of its euploidy, but it basically means that it's just a chance that the nature chooses the leading follicle, and other follicles remain competent. And how do we know that? We know that through IVF, because in IVF, you will see euploidy rates being maintained as age goes, as in younger women. But I also believe that continuous recruitment, and that's my belief, is that continuous recruitment is more likely to occur when a woman is much younger, which basically would mean that a woman recruits follicles in a far a better way. And I'll try and explain that by a triangle which I have devised a bit later. Now, there's a single recruitment episode that there is a single rise in follicles after regression of the corpus luteum. And these group of follicles are decided months in advance. Now, we don't know whether this happens because a woman gets older, and as a woman gets older, her antral follicle count reduces last, and women recruit those follicles much more slowly, and the number of follicles recruited are slowly. So I don't know whether women move from one form of recruitment to another form of recruitment. And the third is what we know is that follicles are recruited in follicular waves. And this picture was taken in Chennai, and that was almost a year and 2 years ago when, before the pandemic, that I visited Chennai, and it was that's where I clicked it. So what we know is that follicular waves there's a wave of follicular synchronous growth of antral follicles, and two waves are generally detected in a woman, which means there's the emergence of 4 to 5 millimeter follicles detected 2 or 3 times in a cycle. And we also know that in the luteal phase, healthy follicles giving competent eggs is present. So what we know is, especially in younger women, is that a woman tends to have one ovulatory pattern. As humans, we'll have only one ovulatory pattern, but we'll have 2 recruitment phases. And one tends to occur very much in the early follicular phase, while the other starts to occur a bit later in the luteal phase. And this is something which lays the foundation of a random start concept, is trying to understand how that ovary is trying to behave. And ovaries don't tell you the same story each time. I think the ovaries tell you a different story each time. And if you start doing ultrasound scanning these women, you'll start seeing a slightly different response. There's some women who have a slightly longer cycle, about 33, 34, 35 days, and evidence suggests that they are probably between 2 or 3 follicular waves of recruitment. And again, what it is trying to tell you is that it's even though our IVF protocols, especially the short protocol and the antagonist protocol, are linked towards following a follicular response, that follicular response in some cases may not be the best time to start IVF stimulation. The second thing what we know is that the luteal phase seems to be where the recruitment window is much wider. And how do we know that? Is we know that if you're used to doing a luteal phase stimulation, and if you look at the evidence, the recruitment of follicles in a more synchronous growth seems to occur better in a luteal phase start, mainly because the time for follicles to start being recruited in that window is much wider than a follicular phase window. So again, we'll say, think of stimulation. So this was a diagram which there's a bit of lag because I tried to record it from my iPad, and the iPad allows you to do that. So years ago, I use this triangle. I call it jokingly the Gudi triangle, because anything good is a 4-letter word, and Gudi is one of them. So let's say that's the ovary, and I draw a triangle in the ovary, and patients understand this much better. And we'll say, what is the aim of the ovary? The aim of the ovary is to produce a follicle. So there's a story that the ovary will tell you, and the story is told via this triangle. So there are multiple follicles, which you can see on a scan, which is known as the antral follicle. And I call this the visible recruitment and a visible loss. Now, there are other small follicles, which to a part is the AMH tells you about, are multiple small early antral follicles, which give you the AMH. And so what women lose first is they lose their AMH first, they lose their non-growing follicles first, and then they start losing their antral follicle. And that's why you see low AMH with good antral follicles at times. So there is a visible recruitment, and there is a visible loss of follicles from the antral follicle area, and an invisible loss that occurs as age advances. So what you're trying to find out is, in this phase, that's exactly where your follicles are recruited. That's where your FSH acts. Your FSH has no action down here. So whatever follicles you see here are the only follicles you'll be able to recruit. These follicles are independent of FSH stimulation. So why is it important? And again, what I think is, and I think there's good research around there, is follicles which are between 3 and 5 millimeter, which are closer to the baseline. Those follicles will get recruited much better and faster. Follicles that are less than 3 millimeter are probably not meant for that stimulation, and probably are geared for atresia and may not develop at all. So this would give you an idea of saying how stimulation occurs. How do you synchronize this? And that's where the question comes up, is you can use a long protocol, or you could start using the pill to synchronize these follicles. But otherwise, follicles come in various sizes, and follicles which are generally between 3 and 5 millimeter or above are more likely to stimulate better. So I tend to draw this diagram and to explain to my patients, what is literally happening. So if you look at a few facts of aging and follicle recruitment, we think that AMH is the most likely marker of ovarian reserve decline. It's also a marker of resistance. But at women age, it may not be a resistance marker. So what happens? And I have this theory about this, that as the AMH declines, AMH is like a controlling person, and it holds follicles back. It holds so that all follicles don't go into atresia and don't get recruited. So it holds follicles back. And as the power of AMH goes down, what does the woman first do? She starts dumping a lot of follicles into the antral follicle range. And that's how you see AMH of 8 or 9 pmol, and you think, oh, that's a bit low, but you see 20 antral follicles. Why? Because the aging process has started and the AMH is declining. At the same time, follicles are being released into the antral follicle environment, and these follicles will stimulate much better. And that's how you'll be seeing them. Also, AMH declines first, and non-growing follicles decline first en route to menopause. Small follicles are more difficult to stimulate. Let it be PCO, let it be poor responders. Small follicles of 2 and 3 millimeter, you'll find it incredibly difficult to stimulate. And larger follicles have less control of AMH and are more easy to stimulate. So can we change any outcome? In simple terms, you need more eggs. And if you look at almost all the studies, and that's what Professor Templeton, he says, the more embryos you replace, the chance of pregnancy would go up. And again, if you look at almost every study, and this is Shesh's 2 papers, and where you looked at it and say, if you produce more eggs, and generally between 8 and 15, your chance of pregnancy got better. And once you start crossing 20 eggs, it doesn't make a huge difference about the chances of pregnancy. So having a better response. The question is, how do you get to those 7 to 8 or 9 eggs in oocytes if you want to get a better response? So what is the entire strategy of stimulation? So if you will say, well, we've not understood how this ovary works, and what we have to decide is, what is the shortest time that we can get this woman pregnant and with the lowest risk of complications? Now, the challenges that we see with ovarian reserve is that the incidence varies widely. Women have a lower number of follicles, they have a reduced granular cell function, and they have got a reduced number of follicles which are responsive to FSH. In some cases, and that is very important to be able to see, because these are the cases where the random stimulation also works, is women who show a good response, a low response, but have a good reserve. There may be, genetic polymorphism, but the question is, what do you do about it? And I think it's trying to detect it is going on a mad goose chase, and I'll say keep that last. And a poor response and poor reserve does not have a single cause. So whenever you see a patient, and I think it's very important to classify what you're trying to treat. Are you seeing somebody with a poor reserve, which is a low ovarian reserve, low antral follicle count, plus a poor response? Or are you seeing a hyporesponder who has a normal ovarian reserve, has an unexpected suboptimal response, and has a low follicular output rate. So I'll just digress and explain to you about hyperresponders, because that also forms around 10% of our IVF cycles, where you anticipate a good response and you end up getting quite a poor response. So again, I'll say divide it, draw two columns, and a poor responder, low AMH, low AFC, and an older woman at times. Poor response, normal AMH, a variable or a normal antral follicle count, probably inadequate stimulation, probably the inability to break the threshold. So, and these are the few concepts. So if you, try to become a member of the Poseidon group, you'll be able to look at all their research that comes in here. And if you look at the hyperresponse, you'll have to look at something known as the follicle to oocyte index and the follicle output rate. So, and this is interesting. So you scan somebody and you see that the follicle has, you've got 15 follicles and only 5 follicles grow. And that is a poor follicle output rate, and that a low output rate of less than 30%. So if you see 15 follicles and 4 follicles grow, that's a hyporesponse. And that's in a woman who has got a good AMH and yet is responding poorly. Now, if you again look at the oocyte follicle index, again, they are parts of the same thing. It's a number of follicles at the end of stimulation. And if you look at the number of follicles, which is more than 50%, and that's a good FOI, and an FOI which is less than 50% is a poor FOI. And this is more likely to occur in good responders. So, and the causes are multiple, and and they are in fact quite challenging, and often we do not know these causes. So always look at going back and said, why has that woman responded poorly? Is it your gonadotrophin dose? Is it the wrong time of stimulation? And that's again where your random stimulation gives you an idea. Is it environmental factors? And we are learning a bit more about it. Is there an asynchronous growth which you may need to correct? And is it all about triggering and using alternative triggers to be able to get a better outcome? So, we've got a general idea of nature. We've got an idea of good responders who are good AMH patients who have a poor response. And what I want you to, the next part of the talk is looked at and say, well, which of these people may have a random start? And also, if you want to do a random start, what is the evidence about it? And what is the evidence about luteal phase start, mixed start, that's a random start, and also about a dual stimulation. And all those, again, are based on that concept that a woman recruits follicles continuously or in waves. And initially, all this came from the lessons we learned from oncology. Why? Because there is a small window of where stimulation can be done. And the patient comes to you and says she's supposed to have chemotherapy or surgery, and you got 2.5 weeks or 3 weeks. And in those cases, what we have noticed is by stimulating the ovaries randomly, routine protocols probably don't work, there's no difference in the quality of oocytes. So in fact, here you can't use the pre-treatment and you can't use the long agonist protocol. So what do we know? We know that follicular recruitment is a continuous phenomena. It is as a wave format. It's not a follicular phase phenomena only. And the peak of antral follicles varies in each cycle. In poor responders, again, the pool of recruited antral follicles may also vary. So what is the mantra here? The mantra here is to know when to stimulate that matters. So can we get more oocytes? And we'll say, first find out what type of a poor responder you have. Do you have a young poor responder, or a woman with a low ovarian reserve who's young, which means that these women have a low AMH, but have a good AFC variability, and those who have a fixed AFC variability. Age is the most important factor that affects success, and women who are older, many of these protocols don't seem to work very well. So you may have an old poor responder with a good AFC variability or a fixed AFC variability. So what options come up in the random start? One is you can try a luteal phase stimulation. You can think of a dual stimulation, or you can think of a random start. And I'll put my experience there of chasing the antral follicle, of trying to find out when the ovary is trying to tell you is the best time to stimulate. Now, in luteal phase start, you start stimulation in the luteal phase around the peak of antral follicle recruitment. It has a wider recruitment window, and the evidence from cancer patients suggests that we can stimulate at any time of the cycle. And we looked at the stimulation between the follicular stimulation as well as the luteal phase stimulation with clomiphene and HMG in poor ovarian response. You saw that the luteal phase stimulation and the follicular phase stimulation did very similar. The mixed stimulation did probably slightly better. And what it is trying to tell you is it's trying to say that, well, it does not seem to matter. These women tend to have a slightly lower reserve, lower outcome, but also if you are able to do a mixed start where you can get a slightly better antral follicle count, you may end up getting more follicles. So can we use this in any patient? The answer is yes. You can use it literally in any patient, but remember that outside a follicular phase start, you will have to freeze embryos. You cannot do a fresh transfer in a random start cycle. So we again said, okay, you have somebody young and they've looked at what happens if you start stimulation on day 2 versus day 15 in oocyte donor programs. Again, so you're replacing the embryos into a recipient, and you do not see a difference between live birth rates. Again, telling us that irrespective of the stimulation window, the quality of oocytes does not change, and it's very much age dependent. So on the back of this came dual stimulation, and I'll say it's probably the most toughest decision to take. It creates a huge financial as well as health burden on patients. And if you're planning to do this, I'll say think very, very carefully before you plan to do a dual stimulation. So you stimulate in the luteal phase and the follicular phase. And the basic concept is for the first egg collection, do not give HCG. And what it has taught us is, and it's, in almost in every meetings, people talk of dual stimulation. And I don't think people do so much dual stimulation as much as they talk about it. But I'll tell you in my smaller concept how these protocols have worked. It teaches us that follicles are constantly recruited, and in poor responders, some follicles may be of better quality in both stages. So the concept is do not drain the small follicles at the first egg collection, and do not give HCG for the first egg collection, because HCG will luteinize all follicles. So this was published on IBM Online, and I heard this man's lecture in Eshrei, and this was a clinician from China, and he presented this paper with absolutely stunning results. He said, I'll give clomiphene, letrozole, and ibuprofen, and started stimulation with HMG, give an analog trigger, collected eggs, restarted stimulation on the next day, and collected eggs again. And I remember there was, in that, it was in one of the small rooms, and I think people thought it was funny. And I think, I did not. In fact, I thought there was something very different, and probably that gave an a spark of saying, let's try something new. So, and this is again one of my diagrams. So we say, let's say you have triggered with an agonist, and you see a very good antral follicle count. That's the only time when you can decide, I want to do a dual stimulation. So if you see that, drain the large follicles, collect the eggs, and start the stimulation at all. And I'm a great believer of adding clomiphene. And the reason I add clomiphene to many of my treatment cycles is that as long as you continue clomiphene, and you will not see a spontaneous LH surge. And also the benefit is that in the luteal phase, the chances of having a spontaneous LH surge is much less than the follicular phase start. So starting the antagonist later is also a possibility. But also, as long as you continue clomiphene, you have a cheap antagonist that is working. And one of the best studies you'll see here from Japan, and also from probably one of the best researchers in India, Mohan Kamath, who has done a donor cycle on just on clomiphene. It was published in Human Reproduction, and it's worth reading his paper. But what happened is that this study showed that the ongoing pregnancy rates were difficult to believe. And the reason I'll say difficult to believe is that we have not been able to replicate this in poor responders. We've also looking at dual stimulation, and they have looked at, let's see the bottom line, the euploidy rate per oocyte collection. And again, you see that the euploidy rate was very much similar, and it seems that women produce euploid eggs at each irrespective. Now, finally, we come to something slightly different of true random start. And a true random start is not saying you can do a random start depending on oncology. So a patient walks into your door and you have got 3 weeks to finish everything. You start stimulating on that day. That is a random start for oncology. But I'm talking of a random start depending on what happens to the antral follicles. And I call that chasing the antral follicles. So let's go back to the triangle. Now, there are some women who have a low AMH, but will have a variable antral follicle count. And if you have and how do you know that? You'll know that by looking at the size of the ovaries. Ovaries, which are of a bigger size, will recruit follicles at a variable way. Ovaries which are small are quite often hopeless ovaries. And in fact, you can't do much about them. And that's what you have a look. Heavy protocols often do not work, and high dose protocols do not create more follicles, but that's a completely different talk where I got it somewhere on YouTube where you'll be able, I've tried to show you the evidence about this. And you can only stimulate what you can see. So it's not, it's sometimes, you know, when you have got a new registrar, you'll say, I'll scan, there were 8 follicles. And then you see 15 eggs and they say, wow, that's magic. And the last thing I looked at it is, you know, in my Indian degree and the British degree, nowhere was it mentioned that I would be a magician, and I'm not. So if you get more eggs than the follicles, you have basically got your scanning wrong. But otherwise, you can only stimulate follicles that you can see. So stimulate, what is random start then? Stimulate whenever the follicle count is good. And if women have a variable recruitment, give her a chance. And the reason I say do it is, it's very easy for us to tell this woman egg donation is your best treatment. But remember, the burden of responsibility of taking that decision almost entirely falls on a woman. And that is quite a big challenge that a woman goes through. So can you change the destiny of a follicle? And it's time that we start changing our thinking about it. So, and this is what I'll tell my juniors. They'll say, oh, she got 8 antral follicles. That's meaningless. Because what you're trying to tell me is that she's got 8 follicles. Now that an ultrasonographer would tell me. I'll say, think about it. Tell me how many of these follicles may respond and how many follicles will not respond. So I'll say, count the size of your follicles, because that will help you to decide on which follicles will recruit and which follicles won't. It's not such a complex science. It's very simple. The ovary gives you that message. And often you are able to, in these cases, predict a poor response. So, you know, you can either start, day 1 is a day of stimulation. I have a habit of giving clomiphene for 10 days often, and I do it to use the antagonist effect of clomiphene and also give a sustained rise of FSH. Now, people say, how does clomiphene work? And all I'll say is I'll look at the Japanese data, but in my experience, I tend to do an FSH level on day 5 for all my cases, and I do it just before I trigger. Why? Because it gives me an idea about the serum FSH levels at the beginning of, at the end of the recruitment window and just before trigger. And you notice that clomiphene gives you approximate an FSH rise between 15 and 18, while FSH gives you a rise of between 20 and 25. So effectively, the rise of serum FSH is quite good with clomiphene. And then if I use, I tend to add HMG a bit later, again, older concept that you need HMG. And what I feel is that once you see dominance, you can start increasing the dose and, trying to recruit that doesn't require. But I'll tell you a slightly different concept a bit later. So you see somebody on day 14, and then you see 2 follicles. You see on day 18, 2 follicles. On day 27, you see, hang on, the corpus luteum has receded, and you see 5 follicles. Start the stimulation then. That's day 1 of your stimulation. Or you decide on day 27, you see 3 to 4 follicles. On day 5, you see the dominant follicles being selected. No, don't stimulate. Day 12, you see that you see a large dominant follicles, and you see another 5 or 6 follicles. Start stimulation then. That's exactly what chasing the antral follicle is. Does it work? Seems it does in some cases, but it doesn't always work, mainly because follicles which are not competent will not grow. So what are the types of random start? And that is basically my thinking. And you could ask me questions and say, why do I come to that conclusion? And I'll say one is the early follicular start, and which is again day 1 to day 4. And that's again a stimulation when which you randomly do, which you normally do with the start of your cycle. So what you're aiming for is what happens at that stage. You see a rise of FSH, and you see a recruitment window that allows the follicles to break. So as humans, we are multifollicular in recruitment, unifollicular in ovulation. So that's how we are, while animals tend to be multifollicular in ovulation too. So what does that initial rise of FSH tells you? If you scan anyone on day 4 or day 5, not on day 1 or day 2, day 3, 4 or day 5, you'll see a multifollicular growth. You'll see multiple follicles growing, because with the FSH rise, multiple follicles start getting recruited. And that is where sometimes starting on day 4 or day 5, you will see a better response. So follicles on day 4 and day 5, they grow from 3 millimeter to about 4 or 5 millimeter. What does that tell you? That tells you that these follicles may have FSH receptors which are present and can be activated better, because you've got the evidence. You can do it in the late follicular phase. So you see a follicle, and you see a large follicle, and the other ovary, you see a lot of follicles. So what is the physiological state that you see here? You see LH that is high, and that is your most challenging factor. You see a high LH, your FSH levels are going down. And so your decision on what stimulation you do is based on recognizing that these follicles are at a high level, but also remembering that LH does not affect small size follicles. And the question will come up is, you can start stimulation there. Question in the past, we would say given antagonists. I've stopped doing that because it doesn't make sense. Follicles will ovulate in the next 2 or 3 days, and that does not have an impact on these small follicles. And I've stopped using the antagonist to knock off this large follicle. The other theory is the early luteal phase, and that is between day 15 to day 21. And the challenging factor is that a corpus luteum is present, and they're increasing progesterone levels. And in this case, it's the only phase in the early luteal phase is that on the basis of high progesterone, and remember, progesterone can affect follicular response in the early phase. And that's that stage where you start giving a high dose of FSH to try and recruit follicles. This is probably one of the most challenging periods of where stimulation is likely to fail. And finally, you come to the late luteal phase, and it's again where the corpus luteum is receding, where the FSH and LH levels are low, the recruitment window is the widest, and your recruitment at this stage, if you have antral follicles, will give you the best recruitment with the best synchronous growth. So in summary, I would say, women recruit competent follicles at every stage of the menstrual cycle. Ovaries can be stimulated whenever the follicle count is good. In oncology patients, random stimulation does not affect oocyte quality. The size of antral follicles may indicate the responsiveness to FSH stimulation, and the ovary will also give an indication. In poor responders, it matters when you stimulate. It's important to realize that the impact of age cannot be reversed. You cannot make somebody younger. And I wish we could all do something to become younger. And finally, egg quality is beyond repair. Medical science lacks the ability to make eggs younger and better. And thank you very much.
Thank you, Dr. Anil. So it has been a real pleasure listening to you. Definitely, it's challenging our basic physiological understanding, and we all know by now that that conventional IVF stimulation is not the only way. And at the same time, despite so many new prospects and new proposals, we are still struggling to get oocytes in a defined group of women. Most of the women we get, but there are definitely defined group of women, like you said, poor responders, advanced stage women, where you are always struggling to get the oocytes. And it's very nice to listen to your perspective, where you have said that go by the number of antral follicles available with potential to grow, and accordingly you decide the time of starting the stimulation. So that's very good. I think that's one perspective, and it has to be, I think, kept in mind. There are a lot of other protocols, like you said, Shanghai Protocol from China. Then there are Italian protocols, and what you were talking about, the random start. Basically, they were all proposed for fertility preservation, where you are struggling for the timing, but definitely they have a very valuable place in the management of poor ovarian responders. And it's very interesting to listen to you. Thanks for the talk.
Thank you very much.
Thanks. Over to Dr. Sarita for the questions.
Yes, thank you, Dr. Anil Gudi. That was really a very, very interesting talk on this subject. And I think we have two questions from, I can see in the chat box. And we have Dr. Sayani Das, who's asking, what are the investigations to be done in a patient, an elderly patient with unexplained infertility? I think, referring to the ovarian reserve.
I think with unexplained infertility it's generally, I still do not know whether ovarian reserve can still be classified as being one of the causes of unexplained infertility, and it's difficult to prove that. I would still investigate somebody who has unexplained in the same way. I tend to do an early antral follicle count. In fact, I never do an antral follicle count on day 2 or day 3 of the cycle. And I detest that. I think it contributes very little and causes more discomfort to women. I tend to scan women usually around day 5 to day 7, because by that time I can see what the follicular FSH has done, and it gives me a better idea of the antral follicle count. Otherwise, with AMH, and I am a firm believer that every woman should have a day 2 FSH, LH, and E2, because I think the younger generation believes that we can do everything without, with just a scan. I think they're wrong. The FSH and LH tells us a lot more. And you'll see that there'll be a small proportion of women where you'll detect hypo, especially in young girls who want to be size 0 and will drop their weight. And you start seeing more and more hypo. So I'll tell reproductive medicine's young people, please don't forget being a gynecologist. But otherwise, all the other investigation for unexplained is very much the same.
Okay. Yeah. We also have another Dr. Pratibha Malik, who's asking, so you start stimulation even before day 1 in poor ovarian reserve. Yes, I think you have said that, but would you like to say that?
Yes, I'll put it this way. I'll say, let's change the onus from us clinicians to the ovary. And I'll say, I tell that to the patient, I'm waiting to find out when your ovary is going to tell me when is the best time to stimulate. So in fact, I see somebody on day 18 and I see a corpus luteum and I see 8 antral follicles. I'll say, see, you have antral follicles. Let's test them. Let's push the ovary now and see if they recruit. And in a certain number of cases, the ovary will recruit very well and produce follicles, and the corpus luteum will disappear. And that's true. I'll recruit whenever the antral follicle count is good.
And typically, what would you start stimulation with in a case like this?
So this is again, you can say I'm wrong, but what I tend to do is, the smaller the follicles, more FSH is needed. The larger the follicles, less FSH is needed. So I'll go by the size of follicles. So if I see follicles about 6 or 7 millimeter, then I use a dose of 150, and I think they respond better. But if I see follicles at 2 or 3 millimeter, small stimulation just does not work. So if you read the recent paper in Human Reproduction, and it is a brilliant paper where they say, mild stimulation for everyone, and it's not for everyone. That's selected patients, and I go by the follicle count entirely, and sometimes I'm right and sometimes I'm wrong.
Okay, so we have Dr. Konkon Mitra who's asking, do you give clomiphene citrate 100 milligrams for 10 days? Is that, I think you showed that in one of the slides. Is that
Yes,
typically for all patients?
No, not for all, mainly for poor responders. I don't give it for all patients. Philosophy tells me I should restrict it to 8, because that is what religion says, that everything has to be multiples of 8.
Okay.
But 10 is a better number, and I like the number 10. And so there's no logic to it. Ideally, I should be giving it till day 14. But I get a bit scared, and so I add the antagonist. But in fact, and whenever patients have insisted on a natural cycle, and I believe that natural cycle happens only at home, and the cost of a natural cycle IVF is the cost of a good dinner and a bottle of wine. Now, but some women say that no, they want to pay me, and that's a good thing to do. And when they pay me, I don't do a complete natural cycle, because my aim of doing IVF is to be able to sleep well at night. So what I do is I give clomiphene 100 milligram or 150 milligram till the day of trigger. And I see a very low level of spontaneous LH rise and premature ovulation.
Okay. Dr. Ranjana, do we have time for 1 or 2 more questions? Because there are some more questions. You're on mute. Yeah.
I think we'll move on to the next session. Shweta? Yeah? Okay, yeah. Thank you, Sarita.
Thank you so much. Thank you.
Thank you very much.
Thank you, Dr. Ranjana, for inviting me.
Thank you. Thank you for coming and honoring us.
Shelly, you want to start now?
Thank you. Shelly. Thank you again, Dr. Anil, for such a comprehensive talk, and you have cleared so many of our doubts. I would also like to thank our chairpersons for their valuable comments and questions. Now, let's move on to our next session of panel discussion. It's on egg freezing, clinician's perspective. With advancement of this reproductive medicine, egg freezing is becoming topic of the today's era. Now, not only we get the females, which demands it for social reason, but there are females who need it for medical reasons. So let's clear out these doubts as well. So for this session, I would like to invite our esteemed chairpersons, Dr. Shantanu Acharya. He's a consultant gynecologist at Gazlo Center of Reproductive Medicine. He's also a convener for international franchise MRCOG Part 2 courses. Dr. Nirmala Agarwal, she's a head of Department of Obs and Gynae Sant Paramanand. She's our past chairperson of AICC RCOG North Zone, very dynamic personality. Dr. Professor Archana Batra, she is a Director Professor, Department of Obs and Gynae at Safdarjung Hospital. She is a current President AOGD. Dr. Anjila Aneja, she is Director Obs and Gynae at Fortis La Femme. She is President Delhi Gynae Forum South. Dr. Shantanu, please invite our moderator, dynamic moderator, please.
Good afternoon, and it's always immense pleasure to come back to India, my home country. And thank you, Dr. Shelley, for the introductions. It gives me immense pleasure to, before I can do that, and thanks to Dr. Sweta for the invitation, and Dr. Ranjana Sharma and Dr. Nirmala. Dr. Nirmala, I was so sad to hear the recent demise of Dr. Shekhar Agarwal. May his soul rest in peace. But next part of the program is very exciting, and as exciting as the moderator, Dr. Sweta Gupta. She's probably known to all as the most encouraging and probably most talented IVF person in Delhi. So she's the clinical director and senior consultant in Medicover Fertility in Delhi. And she has had a fellowship in reproductive medicine. And I just came to know it was in Homerton Hospital, where I had my first job, and Anil Gudi works there. So it's all kind of a small world. And Bhaskar Pal also used to be there. So everybody seems to be from the same place. She is currently the joint treasurer of the Indian Fertility Society and is moderating the next session. Thanks, and over to you, Sweta.
Shelley, you want to call all the, Dr. Anjila will be calling.
Good evening. It's a pleasure to be part of this fertility conclave, and me and Ranjana, we're going to do many things together, AOGD and RCOG. And I would like to invite the dynamic panelist, Dr. Jyoti Bhaskar, who is a senior consultant, Apollo Cradle Indrapuram, and also the president of DGF East, and also a great poetess. Dr. Neema Sharma, Director of Obs and Gynae, Fortis Hospital, Basant Kunj. She's a trainer of TLH courses and basic practical skill courses also. And Dr. Arbinder Dang, who is a senior consultant, Obs and Gynae, Sant Parmanand Hospital, Delhi, and Honorary Secretary, AICC RCOG North Zone 2017-2020. And I think this session is going to be wonderful.
Hi, everyone. Our next panelist is Dr. Nikita Rawal, who is a consultant Obs and Gynae IVF specialist at Vishesh Jupiter Hospital, and she is a founding director of NGO Ishan Foundation. And the next, please. The next panelist is Dr. Jayashree Sundar, who is a dear friend. She is a director and consultant obstetrics and gynae at Madhukar Rainbow Hospital. She is actively involved in our MRCOG courses and perineal repair workshops. And the last but not the least is Dr. Puneet Kochar. She is our young and a beautiful infertility specialist. She is a consultant gynecologist and IVF specialist at Elixir Fertility Center. And she was a former IVF specialist at Bourne Hall Clinic, Cambridge, UK. It's over to our moderators.
Thank you, Dr. Anjila. And I think we just missed your slide, but Dr. Anjila is the president of Delhi Gynae Forum. And also, before I start, I want to thank Dr. Anjila Batra. She is the president of AOGD, and we are really honored to have you here, both of you. I think we just got missed ours with slides, but it's our pleasure to have you both here. And thank you.
We had the slides of Achla.
Yeah, I think it just got missed. I don't know, but we are lucky to have both the president, Dr. Anjila, and Dr. Anjila with us. And we'll start this session. Let me just share the. So these are our panelists: Dr. Jayashree, Dr. Puneet Kochar, Dr. Arbinder Dang, Dr. Jyoti Bhaskar, Dr. Neema Sharma, and Dr. Nikita Rawal. Dr. Arbinder Dang is our very active in RCOG, and she had been just recently, she was the secretary, and Dr. Shelley has just taken over. So Dr. Arbinder, you are also here. I hope you're fine. Yes. Okay, so we'll start with our fertility preservation. And before we move on to some cases, I'm just going to present few slides on the basis, on the history of the egg preservation. The egg freezing for preservation of fertility is a relatively new technology, and it allows the reproductive autonomy of women and can be used for elective fertility preservation in women who are conscious of age-related fertility decline, but are not ready to become pregnant. Now, so the interested women should be provided with a personalized evidence-based estimate of the number of oocytes and the number of cycles so that they would need for successful reproduction. And some of the common egg freezing indications are advanced stage, treatment with therapeutic drugs, and pelvic radiotherapy for cancer, for hematological diseases like leukemia, Hodgkin's lymphoma, non-Hodgkin's lymphoma, and breast cancer. Women who have the risk factors which may be candidate for fertility preservation before ovarian failure starts, like endometriosis, who may experience reduced ovarian reserve post-surgery, autoimmune disease requiring gonadotoxic treatment, primary ovarian insufficiency, then fertility preservation in gender reassignment surgery, then emergency oocyte freezing when male is not able to produce sample. We all know that with advances in medical science, natural life expectancy has now moved to 80s, but the fertility life, especially of a female, ends at 40. And the ovarian reserve, which a lady has at birth, which is about 2 million, drops down to 25,000 at the age of 37 to 38. There is an accelerated loss and increased difficulty of spontaneous conception. This is not just in the numbers, but also the quality of the egg also goes down. The down rate increases. So what a lady can have a probability in when she is young at age of 20, 1 in 1400, this actually comes down to 1 in 84 at the age of 40. And if we do IVF very much late, then we know the success rate of IVF also goes down. So around 40 or thereafter, the success rate is about 5% or even less. But of course, when we use the younger eggs of donors, that again success rate improves to 60% or around. So there are advantages of ovarian cryopreservation. It provides them with the possibility of becoming a genetic parent using this frozen thawed eggs. It also reduces the risk of having children with chromosomal abnormalities associated with ovarian aneuploidy. In addition, for example, who do not have partners or who have moral concerns about the status of developing embryo. Now, egg freezing is a preferable alternative to embryo freezing. So ASRM, that is the American Society, has announced egg freezing as a first-line fertility treatment, as it was formerly experimental treatment, which title has been lifted in 2012. In fact, at that time, the chair of the society said that oocyte cryopreservation is an exciting and improving technology and should be no longer be considered experimental. The pregnancy rates and health outcomes of the resulting children are now comparable to those of IVF with fresh eggs. So fertility specialists should be careful not to raise false hopes. Women interested in oocyte cryopreservation for age-related fertility loss should be still told that their best chance of having a child are through natural reproduction at a relatively younger age. Fertility preservation should be presented as a preventive measure for those needing or wanting more time that increases their chances but offers no guarantee of success. So if we look into, what is the estimated number of eggs or retrieval cycles which are necessary for birth of one child at different age, the rough idea is that if it's a younger lady, then maybe 10, but if the age of the lady is about above 38 or 39, 40, then the number of eggs required are more. And obviously, if the more eggs are required, then she may have to go more number of freezing cycles. In our RCOG last year, the scientific impact paper was published, and where they have reported that the European data indicate more than 90% of cumulative live birth in women who had elective frozen egg at younger age, less than 35, and although that require utilizing 24 eggs. The storage of 10 eggs, if we have 10 eggs, that can give a cumulative live birth of 42.8% compared with 25.2% in women aged 36 and over at the time of storage. In the UK in 2016, 32% of women freezing their eggs were under 35 years and 62% under 38. Now, they even said that the marketing the technology as a form of reproductive insurance is inappropriate given the limited success rates in the women most likely to freeze eggs. Just quickly, we have now advances in the lab freezing. Earlier, we used to use slow technique. Now we have moved on to the rapid vitrification. And this new technique, vitrification, which is rapid freezing, has shown to reduce the risk of ice crystal formation during freezing and improve oocyte survival after thawing, as well as increase live birth rate. So the evidence suggests that the pregnancy rates after IVF or ICSI with vitrified oocytes are similar to that for fresh oocytes, and no increase in chromosomal abnormalities, congenital anomalies, or developmental delay in offsprings from pregnancy resulting from cryopreserved oocyte versus the general population. So we start with the cases, and the first case we have is a 36-year-old lady who is a high-profile job, works in an IT company. She is in relationship and she wants to delay marriage and pregnancy, and she has come to gynecology clinic for egg preservation. So what will be your advice and how will you counsel her? And I think Dr. Arvinder, do you want to start with this one?
Okay, ma'am. So she's 36 years old. We know that as the age advances, the quality of the oocytes decline. So we need to take a history from her, check with her whether she has any medical problems. We need to inform her that 36 years we can do an oocyte preservation, but she needs to understand that the quality of the eggs, the quality of the eggs, the number of eggs which we get may not be, adequate, because we need 8 to 10 eggs to freeze. And we need to tell her that if she gets pregnant after 36 years, then she may have medical problems which can ensue. So all these things need to be told to her.
Yeah. And if she asks what will be her probability, then we have this study from Swedish, where they said that if they have 20 mature oocytes, then probability of one live birth is about 90% if she has 20 eggs. And also there's another study by Koba et al. Where they said that if women who are less than 35 years of age or younger at the time of vitrification, the cumulative live birth rate was 60.5% when 10 oocytes were used. Whereas if a woman who is more than 35 years of age at the time of procedure, the cumulative live birth was 29.7% with 10 oocytes. So half the rate obtained in younger group. Dr. Jyoti, do you want to add anything?
Yeah, definitely. This patient, if she has come to me, first of all, I will tell her, yes, if you're going for an oocyte preservation, that still she needs to rethink about it. Because she's 36 years, she already has a partner. Instead of going for a particular preservation, what she's going to do is she's going to delay her pregnancy. And we need to explain her the risks of a pregnancy which is at a delayed age. The risks which include increased chances of having PET, increased chances of having GDM, more of cesarean section, and use this opportunity to try and tell her that she should try and get married or maybe in relationship, have a child naturally, instead of going for this particular procedure. Also, we need to counsel her about the cost. As you did show in the previous cycles, depending upon her AMH, depending upon the number of eggs that she has, how many we are able to going to recruit or get the eggs. If you're going to get less number of eggs, she may require more number of cycles to reach an 8 to 10 oocyte preservation. So the cost also has to be explained to her very well before she embarks on this particular pathway. So we need to tell about the cost, the process detail. We need to tell about the risks that she can face during the particular process. And the risk of OHSs is also actually a risk that needs to be told her that if she goes through the procedure, she may have a chance of OHSs as well as the problems of oocyte retrieval. Having counseled her very well, if she still insists that I need to go in, then definitely one would take her up and offer her about the oocyte preservation. So if you need to really move ahead, and should I talk about?
She's been referred from gynecology clinic, and as a fertility specialist, she has come and she said, no, I still want, and I am too much involved with my career and I can't take out 9 months of time. So I would still like to go for freezing, and I do understand there's no guarantee, and she wants to go ahead.
So yes, of course, then that's her choice, and it's my duty to be able to offer the best possible treatment that we can provide to her. So she needs a pre-IVF assessment as we do for any other patients. That would include all her investigations, definitely her AMH, the age, and the BMI. Having done that and an ultrasound and see what her AFC exactly is, based on that, we're going to start her on a stimulation, preferably on the day 2, the conventional treatment. That is the antagonist protocol. That is the one that we're going to follow it up. Now, exactly the amount of gonadotrophins that we're going to give will depend upon, again, about the age. She's 36 years, what her BMI is, what her AMH is, and what her AFC is. Based on that, we start her with gonadotrophins. We continue the gonadotrophins, then based on the fixed or the flexible protocol that's available at the IVF clinic, we start her on the ANTAC protocol. The reason for using an ANTAC protocol for her is that the dose of gonadotrophin that we're going to use is going to be less, and this tends to decrease or minimize the risk of OHSs that she can face during this particular stimulation. Once we follow it up with ultrasounds and once she's ready, then give her a trigger. The question then allows over here is what trigger do we need to give? Now, since we are going to go in for an oocyte preservation and we do not want any risks of OHSs developing in her, so I would say that the best trigger would be to give her an agonist trigger to be given to her. Follow that, 35 to 36 hours later, we tend to collect the oocytes, do an OPU, and after that, subject the OPUs to a vitrification. And then once we do have the number of eggs, we of course need to counsel the patient as to how many eggs we have been able to retrieve. And then in future, whenever she needs, she can come back to us. So that is a procedure that we're going to follow in the IVF clinic after having counseled and done this particular procedure.
Okay, yeah, so great. Thank you, Arpinder and Jyoti. Now let's move to another interesting case. So here there is a transgender and she wants to change from female to male, and she came to inquire about fertility preservation. Already the mental health assessment is done, and she is on hormonal therapy and would be going for gender reaffirming surgery soon. So Arpinder, do you want to, how will you proceed in such case?
Yes, ma'am. Since she has already gotten her mental assessment done, this is a female to male transition we are talking about. That means a female who wants to become a male. So she has already started a hormonal treatment. That means that she has been taking testosterone to convert to male, and various doses of testosterone are given for that. And usually now she has also decided to go for gender affirming surgery. But before that, she wants to go for cryopreservation. So we need to counsel her that she has to stop that therapy which she has been taking, that is the testosterone therapy, because that can interfere in, if we do go for oocyte collection, that can interfere with the quality of the oocytes being collected. The very fact that they have to stop the therapy and then go for oocyte collection can itself cause dysphoria for them, because they are already accustomed to being a male now. So they have to stop that therapy and then they have to go for the oocyte preservation thing. So they have to, that thing can itself call distress. So they have to be counseled properly that all this thing will need a little time. It may need 3 to 6 months. They may have to go for various transvaginal sonographies, various pelvic examination. They may have to go for an oocyte retrieval procedure. So all this can cause distress to them. So we need to counsel them thoroughly for it and then only go for it. So they need to be told all this. They may have to visit a fertility clinic, which they may not be comfortable with because they feel that they are male now. So all this needs to be counseled, and yes, we can go for it, but they have to stop the therapy. Then only they have to go for the oocyte retrieval process and the oocyte preservation. And we need to tell them that how many number of 8 to 10 number of oocytes will be preserved for them. The best time is less than 36 years of age. All this thing needs to be done. If they have any medical problems, if they are facing any medical problems just because of testosterone therapy, we need to tell them. We need to tell them that testosterone can cause, it can increase the erythropoietin polycythemia. So on top of that, they are going to get an OHSS. If they get a OHSS type of a problem, then all these things need to be counseled and told to them.
Yeah, Dr. Jyoti, you want to add to any more?
I think Dr. Arbindra has covered up nearly everything, but the only thing that I would say, I would congratulate the person, actually the endocrinologist of this particular trans men who has referred the patient to an FP. You actually look at all the studies who have really done this, they have found that less than 10% of these trans men actually are offered the family planning procedures. And all those who are offered, less than 7% actually come to take up the family planning options. So the thing is that as gynecologists or maybe as doctors, if we do get a trans man who wants to convert, it's very important to have this discussion of a family planning option that they do have. Because various studies have, they've interacted with these people, that 50% of them did say that probably had they been offered, they would have been able to take this particular option even before they went in for the surgery. One option that she has said is that this particular patient rightly came to us before she went in for the surgery. So in case sometimes we do land up getting a patient who's already scheduled for the surgery very next day and who's not willing to wait to stop her testosterone therapy and then go in for a stimulation after that, then yes, we do have an preservation, although at present it is still in the experimental stage. But yes, that is a valid option. But the problem that occurs in the trans men as compared to cis women is that in a cis woman, you can, after whenever she does want to get pregnant, you can put the ovarian tissue back into her. But these people who've already undergone surgery, they've had a hysterectomy, they've had an oophorectomy, and it's not possible to put this particular tissue back into the body for them to be able to do it. So then the option lies that we can have IVM done with them. So where we tend to mature these particular cells with an IVM and then consider transfer. The same thing we need to also consider for the prepubertal adolescents. So over here, yes, they have already reached puberty and they've come, but some of these young children who are prepubertal and they have these particular gender changes. So in such particular cases, we are giving them agonists, and that time also there's a role of these particular OTC. But yet at present, we do not have a single case in the literature, which I did come across, of a pregnancy occurring because of this particular OTC and being transferred as yet. But yes, we should be aware that this particular option is available.
Here I want to add that in the pre-pubertal, they go to the gender identity clinics, and this thing needs to be discussed with them regarding fertility preservation. It is one of the very important component which needs to be discussed with them, because we have gone through the literature, Dr. Jyoti and myself, and we found that less than 20% of the people are counseled for it. So we need to have that thing has to come. That counseling needs to be there for the fertility preservation, especially when we are talking about transgender population.
So this is a very good study which I picked up, so this is from Israel, that they thought that, because we don't actually counsel the when they come, we don't have those multidisciplinary in India as yet as a routine. So here the 45% of prepubertal transgender females and 6.5% of pubertal males completed fertility preservation. So we actually don't offer them because probably the awareness is less and there is less availability of joint clinics or referring to the concerned department. I think that's a very good important point, that we do nowadays get to see the patients, such patients transgender, and where we should discuss this as one of the option before they actually go on to the surgery. Thank you, Dr. Jyoti and Arvinder. Now we'll have another case which is very much commonly seen by all the gynecologists. She is a 33-year-old and she has a history of painful and heavy periods. She has been married for 3 years, no children, and she's keen for pregnancy. And an ultrasound, she has a recurrent endometriotic cyst, 3 centimeter. So, Dr. Jayashree, how you would like to proceed in her case if she has come to your gynecology clinic? Dr. Puneet, you want to take this one then?
Yes, ma'am. So I would again need a detailed history from the patient first. We say that she's been married for 3 years, but how long has she been trying for a pregnancy, and what fertility treatment has she had before coming to me as a fertility specialist? Now, there could be 2 possible scenarios. First, that she's only tried naturally for a few months, and she probably had a surgery or a laparoscopy for an ovarian cystectomy done either before or after marriage. Now she has a recurrent cyst. Now, in these cases, it will depend on how severely the pain from the endometriosis is affecting her lifestyle. So there is no role of medical management in the management of infertility with endometriosis, because if we give her oral contraceptive pills, they are going to suppress her ovulation, which is not going to help her in getting pregnant. On the other hand, if pain is a primary concern, then she does need a surgery before going in for fertility treatment. So if pain is more, then we plan her for a laparoscopy, do an ovarian cystectomy. I think a gynecological or a laparoscopic surgeon would agree that ovarian cystectomy is considered better than just drainage and ablation of the cyst. Now, in this case, because she has a recurrent surgery, we need to assess the ovarian reserve before taking her up for a surgery and counsel her that repeated surgeries can actually decrease her ovarian reserve. So again, we come back to the point, let's say the AMH of this lady is already on the verge of being low. So it could be 0 point something, it could be 1.1, 1.2, anything less than 1.5. In these cases, there is an option of undergoing a pickup procedure, stimulation and freezing of either the oocytes, or in this case, she's married, so we can actually freeze the embryos rather than the oocytes before doing the laparoscopic surgery. On the other hand, a lot of these young women have actually a good ovarian reserve. And let's say we are not planning an extensive surgery and the woman is not keen on an IVF cycle because she's not had any fertility treatment. We still need to counsel the patient that her reserve may decrease, but since she has a good chance of having a good number of follicles left even after the surgery, and she may not end up requiring an IVF, we have to give the couple an option of going through the laparoscopic procedure followed by a series of IUI cycles with controlled ovarian stimulation before an IVF. So most of these patients will actually go in for a series of IUI procedures before proceeding for IVF. Nevertheless, it is a duty of a fertility specialist to offer them a pickup before going in for freezing. Let's say about 20% of these patients will actually benefit from pickup before the laparoscopic procedure. On the other hand, as I said, maybe the patient has already had a few fertility treatment cycles. These are the patients where freezing becomes imperative. These are the patients where an IVF is already planned, but because of a pain, we want to do the surgery first, and we are not waiting for, we are not wanting an IVF before a surgery. So these are the patients where we must do a pickup, where we must give her controlled ovarian stimulation and take her up for a pickup procedure, then freeze the embryos and further plan a laparoscopy and then a frozen embryo cycle.
As rightly said, that there can be, one should know that there can be a decrease in AMH in up to 30% after excision of a unilateral endometrioma and up to 44% excision in bilateral endometrioma. So women with endometrioma should be counseled about oocyte cryopreservation for fertility preservation before surgery. And now, this is one of the flow chart. I think if you want to go through this, Puneet, which is I've found quite systematically that you have a pre-op endometriosis patient desires fertility. There are some conditions, especially like the bilateral or unilateral endometrioma with history of surgery for contralateral endometrioma or history of multiple surgeries or at risk of multiple surgeries. If these things are yes, then you can consider the fertility preservation. And of course, if she has a partner, then we do the MTO cryopreservation. If not, then we can have the oocyte cryopreservation. So a very nice practical approach has been here made. And of course, if there is, the other side, of course, it is related with the age. Also, Dr. Puneet, you wanted to add something more?
So when we were discussing about assessing the ovarian reserve, again, it's not just the AMH that we look at. We look at the age of the woman. I think the age mentioned here was in early 30s. Yes. So let's say we have a woman above the age of 35, more than 3 years of duration of infertility, AMH less than 1.5, FSH more than 9 or 10, and a low antral follicular count. These are the women where, again, even if the surgery was a primary surgery, even if she hadn't had a previous endometriosis surgery, for women with more age or longer duration of infertility and a lower reserve, we counsel them, even if they're undergoing the first surgery for endometriosis, that they should have a stimulation cycle and a pickup procedure done before proceeding in. On the other hand, let's say we have a younger patient like our case here. So she's only 32, trying for 3 years, maybe no previous fertility treatment cycles. If the AMH, the AFC in such a patient is good, let's say she has an AMH of 3.5 or 4, she has an antral follicular count of 15, 20. And yes, some patients with endometriosis do have a good antral follicular count. So such a patient, if after informing she chooses not to undergo a pickup procedure, that should be okay.
Yeah. Yeah. So it's just that we have an option now where we can do egg freezing, it should be told, but of course you have to individualize each case and take the patient's options into mind. So I think that is a good message. Let's go on to another case where there is a 30-year-old who does not have children, but there is a family history of early menopause. And she has come to gynecology clinic and she has been worried that in my family this has been happening. And she is of course keen of pregnancy later, so but not yet immediate for pregnancy. Do you think you can, how would you like to counsel her, this patient?
So again, we start from the history of a patient. So the foremost important thing is when we say family history of early menopause, at what age was this menopause in her mother or sisters observed? So because a patient is usually likely to have a decrease in the ovarian function at a similar point in life as her mother or her sisters usually, which is why the age becomes important. She's 30. Let's say her mother had a menopause in her early 40s. That would indicate that this patient is going to have a faster decline in reserve, but it may not be as bad as somebody whose siblings have had a menopause in early 30s or mid 30s. So first comes the history. Then comes the assessment of the reserve again in this patient. So we need to do a day 2, day 3 FSH LH. We need to look at the antral follicular count. We need to check the AMH of this patient. If all of them are absolutely within the normal range, then the patient has a history. So I would actually counsel the patient to consider getting married in the next 1 or 2 years and try for a pregnancy naturally. However, one, if she does not want to do this, or if her reserve is already borderline, then we can go in for a ovarian stimulation cycle, controlled ovarian stimulation, and do an egg freezing for social indication in this case.
So just that, sometimes we don't have this, sort of awareness, and we never give a patient an option. But of course, here also it's a patient's choice. But there is something where she may benefit from prophylactic oocyte cryopreservation before actually the ovarian function declines.
Yes.
Okay. Thank you, Dr. Neet.
And ma'am, actually, in the mid 30s, so let's say 30 to 35 is a better age for egg freezing than after 35.
Yeah.
Yeah. When we say we can counsel and give her the option should not be for the next 4 years. Maybe she's already seeing somebody, maybe she can wait for 6 months or a year at the most. But this is the right time to go ahead for freezing if she does want that.
Yeah. Okay. Yeah. So we have another 2 cases of oncology. One is the 31-year-old who has a Hodgkin's lymphoma and she's planning for chemotherapy. She's been married but no children. And how will you proceed in this case? What option you can give? Maybe Dr. Nima, if you are around. Dr. Nima or Dr. Nikita?
Yeah, I'll take the case.
Yeah, so Dr. Sweta. So this is a young female, 31-year-old female with Hodgkin's lymphoma. We all know that Hodgkin's lymphoma is a malignant disease, but with a high curability. The 5-year progression-free survival is almost 87%.
Yes.
And these are young girls, young women. So they need all kind of counseling for fertility preservation. So most important in these young girls is that they should be managed by a multidisciplinary team. There is an oncofertility team, which is not very prevalent in India, but yes, there should be a oncofertility team or a multidisciplinary team, which will have a gynecologist, medical oncologist, and IVF specialist to deal with such kind of cases where they can be counseled, they can be, told about what all fertility options are there. So in Hodgkin's lymphoma, in this young patient, first and foremost thing is to stage the disease. This is because the fertility option, the risk of damage to the gonads will also depend upon the type of treatment which we are giving to these younger patients. Suppose if it is an early stage of Hodgkin's lymphoma, which requires a shorter duration of chemotherapy like ABVD chemotherapy, the risk of ovarian damage is almost less than 20%. But if she requires a long-term chemotherapy or an advanced chemotherapy requiring a lot of alkylating agents like MOPP and other kind of chemotherapy, the risk of ovarian damage is almost 50 to 95%. So this needs to be explained to the patient. Even in early stage of Hodgkin's lymphoma, if we if we have to decide and give radiotherapy to these patients, we need to explain it to them that almost 5 gyrons can cause infertility in almost about 30 to 40% of the cases. So this counseling is an important aspect which needs to be explained to the patient so that the patient can be referred to an IVF colleague who can decide what is the best modality, the embryo or the oocyte cryopreservation. From oncology part, there's another very important thing which we have to see is that there are no cancer cells present in the ovarian tissue. This is because like in ovarian or even in solid tumors like Hodgkin's lymphoma, if there is metastasis to the ovarian tissue, then you can't go ahead with the fertility preservation modality. So that should be screened for and counseled. I mean, patient needs to be counseled about that.
Yeah.
In addition to starting, another very important thing is time, because these patients, we need to start chemotherapy fast. So we need, our IV colleague will have to decide whatever best is possible so that it can be done, as early as possible. Yeah. And one more thing is before this thing, another thing is during chemotherapy. There's another important concept of GnRH analog. So it is debatable, but still it has a role when patient is on chemotherapy. It has little protective effects on the oocytes. So should be offered to these patients. And when we are giving radiotherapy, obviously gonadal shielding or fractionated radiotherapy should be offered.
Okay.
So
Dr. Nikita, you want to add something?
Yeah, so now she's been thoroughly counseled by Dr. Nima and she comes to me. So I need to give a realistic expectation as what fertility preservation involves and what are the success rate and how much time she has got. The survival rate is good, but the treatment does affect the fertility to a great extent. So the options we have got, like in this case, she's 31. So I'll do an assessment of her ovarian reserve, which includes, of course, the AMH ultrasound scan, which has been covered before. And then as she's married, the embryo cryopreservation will be the best option for her, which will involve ovarian stimulation. I will use a short antagonist protocol. And because we have to start the chemotherapy early, we can do the random cycle stimulation as very well explained by Dr. Gudi in his lecture. And the studies have shown that it gives good success rate. The oocyte recruitment is as equivalent to as the normal day 2 start of the stimulation, and the fertilization rate is good. Suppose this lady is not married, then we go for the oocyte cryopreservation. Again, a random start of stimulation will be preferred in her case. The problem arises when the age of the patient is less and they present to you with lymphomas. Then, of course, you don't have the options of oocyte cryopreservation. Then you go for the ovarian cortex or the ovarian, you take out the tissue, ovarian tissue by laparoscopic surgery, and then you do the IVM maturation. Once the patient has completed the treatment, then you transfer the ovarian cortex back, and that restores not just the reproductive function, but the endocrine functions as well. So in this lady, the best option is the embryo cryopreservation, and the success rates are quite good. And the oocyte cryopreservation, again, is not just an experimental thing now. It has given good success rate, and the emphasis will be the short cycles, random start.
So planned ovarian cryopreservation is an adequate method for fertility preservation. However, knowledge gaps result in underutilization, leading to reduced cost. This is one of the meta-analysis. Similarly, we have another case related with oncology. She's a 32 years old, BRCA mutation positive. There is a family history and wants to delay marriage and pregnancy. Though she is in relationship and wants to have children in future. So how would you go ahead in such case?
So Dr. Sweta, again, BRCA mutation needs a lot of counseling. Lot of counseling to these younger women about their risk of having a cancer and what strategies can be offered to them. Like women with BRCA1 mutation have a lifetime risk of ovarian cancer by age 70 as 63%. And breast cancer risk is up to 85%. And with BRCA2 mutation up to age 70, the risk of ovarian cancer is 27%. And the breast cancer risk is 84%. So we need to counsel them that there is risk of hereditary breast ovarian cancer to these patients. then we need to talk about the risk reducing surgeries. Definitely, these risk reducing surgeries have decreased the risk of ovarian cancer by almost 80 to 96% in BRCA1 and 2 mutation studies. And definitely, this also has reduced the risk of breast cancer by almost 50%. So this risk reducing surgery should be done in BRCA1 at around about 35 to 40 years and with BRCA2 at the age of about 45 years. So they need to be counseled that they should plan their pregnancy as early as possible so that, you know, these fertility, these risk reducing surgeries can be performed. But if still she's not willing and we have explained all the risk factors associated with it, then the patient can be referred to an IVF colleague so that they can, you know, explain them all the options to them. But in addition to that, during counseling, it's very important to tell them that these mutations are transmitted to the baby. You know, these can be transmitted to the baby. So that comes the importance of pre-genetic testing. So this should be explained to them before they go for IVF. This is because this has a lot of emotional and psychological impact on them. Yes. You know, so they are well aware of it before they go for any fertility preservation methods.
So Dr. Nikita, if she has come to you as a fertility consultant, how would you like to counsel her?
Yeah, of course, the initial assessment of the patient and telling her what are the risks, assessing the ovarian reserve. And it has been seen that the patient with BRCA mutation have a less ovarian reserve as compared, like when we do the stimulation, we get less oocyte as compared to the normal counterpart of the same age. So everything has to be explained in detail. If I have sufficient time, then again, I will do my traditional stimulation of day 2 with antagonist cycle. The most important thing in their stimulation is many of these tumors are estrogen sensitive. So adding letrozole, which is an aromatase inhibitor, is of great benefit in this cycle because it will just prevent those estrogen peaks, as well as it increases the response to the gonadotropin stimulation. So in this particular cases, I would like to start with the letrozole at the start of the treatment and maybe continued even after the pickup till the estrogen levels come down. And of course, if we are short of time, then random start of the stimulation can be done. If she is married, then of course embryo preservation. If not married, then oocyte cryopreservation, which has got very good results. The oocyte pickup rate in these women is quite good, but the fertilization rate is slightly less as compared to the normal same age control ladies. The other thing which Dr. Nima has stressed on is the risk of passing the mutation to the offsprings. So it's very important in the counseling that we explain the role of the pre-implantation genetic diagnosis. So whenever we do the IVF cycle, we will go for the embryo biopsy, select the embryos which are normal, healthy embryos, and then transfer those embryos. So these 2 points are important in her care, I think.
Thank you. So of course, we have already covered that ovarian tissue, especially in prepubertal cases, is an option which is available. And I think somebody has already mentioned that it is no more experimental. It has become, just very recently, 2-3 months back, American Society has made it as a standard treatment. So ovarian tissue cryopreservation is no longer experimental. So this is, you know, they have now a good number of studies and it should be offered, and especially in prepubertal cases. And in some of, like here, it has been mentioned that if there is no time for ovarian stimulation, ovarian tissue cryopreservation should be proposed, and it should be proposed especially for the prepubertal girls. And of course, the other topic is transplantation of frozen thawed tissue allows natural conception. So it was earlier, but now it has become as one of the standard. Very recently, American Society has withdrawn the status of experimental. And apart from all these things, of course, we should remember that we have to explain to the patient cost of not only the egg freezing or stimulation, but annual freezing charges, and later on ICSI and the FET charges. So in conclusion, we must have all good, you know, awareness and availability of extensive counseling on oocyte preservation who wish to access these services. Counseling should promote long-term reproductive plans and providing a realistic oocyte, realistic assessment of the advantages and the potential failures of oocyte freezing. And of course, as rightly mentioned by some of our panelists, that the timely referral is of course most important. So I think with this will end this session, panel discussion. But if we have any questions, we can take that. I think Santanu is here. Dr. Santanu, do you want to just add on few more points?
Yeah, hello, hi Sweta. Yeah, I think I wrote down in one of the queries that one of the attendees posted regarding surgery for endometrioma. And she was asking that whether a 3 centimeter endometrioma needs draining. I think the current evidence suggests that you do not need mandatorily to drain a 3 centimeter endometrioma beforehand. However, you need to counsel the patient because you have to see the pros and cons of both, because one, that it leads to more infection rates when you go through the endometrioma, which you can cover with antibiotics, or it might be sometimes tricky to approach if you have just one egg, one follicle, and it's a large endometrioma. In those cases, you may wish to drain it. But vis-a-vis, you might want to consider that she might be losing quite a lot of normal eggs and also delay the IVF cycle. So currently, we do not necessarily take all the small endometriomas out, but one has to also remember the very small risk of malignancy, which can be harbored within large endometriomas, especially like 8 or 10 centimeter ones. And those are the ones which we tend to operate.
I also agree with Dr. Shantanu. We do surgery only if it's indicated. Otherwise, we will end up with a very low egg reserve and very low number of follicles, and we will hamper more fertility of our patients. We do only endometriosis if the patient surgery, if the patient is having a lot of pain, and and once we are trying to retrieve the eggs, and it's inaccessible,
Yes.
Yeah, only then we will do that. Otherwise, we are moving towards more of the conservative approach rather than the surgical approach. We have gone a long way. We used to operate.
There used to be at one point of time a cutoff of 4 centimeters, somehow complete arbitrary 4 centimeters. But no, now we have moved away from that.
Yeah. I think you have covered.
So can I ask a question now? Dr. Anil Gudi is here, or he's? I can just see his. Okay, so Sweta, maybe we all can discuss. So this random start stimulation. So can we extend the use to people who come from abroad and they don't have time, and just that maybe the indication? They are not poor responders and they are not oncology patients.
So, ma'am,
they are just normal people.
Yes. So very rightly, those kind of practical scenario where the patient has come internationally and, they may not come on day 2, day 3. And in today's time, waiting for a month is actually very not only practically possible for the patient, but even, the doctors start getting, because now restless, because there is a very good system. This random protocol is available. And of course, if you do a very good scan, as suggested by Dr. Gudi also, I have personally also done few random stimulations. The only thing is that in those cases, you have to freeze off. And then I freeze it. And of course, in the next cycle, then we prepare the good endometrium. So in the first time, we just take out the eggs, we make good embryos and we freeze it, because now the vitrification of freezing has become very good. So earlier it was not so good, but nowadays the vitrification success rate is going up to 97, so 98, in fact, very almost touching 100%. So we can freeze it, but in next cycle, we prepare the endometrium very nicely with, estrogen, and we transfer it as we do frozen embryo transfer.
So as we have not moved to frozen embryo transfers 100% in India, you know, we still do the same cycle, right? Lots of them. So in terms of saving time, if they come from outside, do we really, is it really beneficial to them? Because now we are going to freeze, because for random start, Dr. Gudi said, you know, it should always be a frozen cycle, right? Frozen embryo transfer. So then are we really saving time? And we'll also increase the cost, because we will charge them for freezing, then thawing and everything, right?
But even then, you know, ma'am, if she is around mid-cycle, and if we do 15 days or 12, 14 days of stimulation, after a week, usually they get a period. So when we stop, you know, the progesterone, or, you know, after the egg collection, they usually get very early period rather than, you know, that waiting for another. So overall, there is a reduction in the whole time of the till from stimulation to the cases of, you know, the final ET. But there are some cases where actually, even if we do day to start, if suppose she is a PCO patient, she will require, for her own safety, she will require freeze-all. So in that also we have lost another, because otherwise she may have a risk of hyperstimulation and OHSS. So because of the very good technology of freezing, we have become somehow, and in fact some of the studies say that, you know, actually if you you do a freeze all and you transfer in next cycle, the result might be better, though not in all the cases, but in selective cases, rather than, you know, transferring the embryos in a stimulated body, and where there's a high risk of hyperstimulation, or if there is a problem, you know, in selected cases, if we find the endometrium is not good, we anyway do the freeze all and then transfer in next cycle.
So we'll definitely be safer.
Sweta, I'll just add there, Sweta, there is an e-freeze trial going on right now, which is led by Professor Maheshwari, one of our own, Abha Maheshwari in Aberdeen. And that would give you the answer, because now more and more there is evidence emerging that if you are freezing all and then subsequently transferring at a later cycle, not only that, what we knew that it would reduce the risks of OHSS to zero, but also actually they're saying that the success rate would be better. And that's basically eliminating all the hormones away, especially the LH and progesterone, and then subsequently transferring. So it may be that once we get the e-freeze results back, then that would be the proper protocol that we will all follow. We don't know yet, but probably that's where we are going.
Dr. Ranjana, I'd like to add something here. So when you say international patients, most of these patients who are traveling specifically to India for IVF treatment would actually contact a center, an IVF center, asking for advice before starting the treatment. Usually we ask them to get the basic test done and put them on contraceptive pills before they arrive here, and plan the cycle in such a way so that they arrive here just before a period is due. So usually most of these patients will not land at the center randomly anywhere in the cycle. But yes, you're right. If they, let's say we happen to see them in the middle of the cycle and we are wanting to do a random start. So there are two things, as Dr. Sweta said, we need to counsel them about. The first would be, yes, she will definitely need a freeze-all. So some of the women, even if you're starting on day 2, either because of a thin endometrium or because of hyperstimulation, do need to freeze the eggs anyway. But these women who are being started randomly, even if everything is in place, so even if she has a beautiful endometrium, no OHSS, we still will need to freeze all if we're starting later in the cycle. The second thing is, sometimes we get a suboptimal number of eggs. So sometimes starting the stimulation later in the cycle will give us probably a fewer number of eggs than we would have produced had we started on day 3. So these are the two things that I'd prefer to counsel a patient about.
Yeah. So, you know, coming and very planned coming is, I don't agree, because the market is open. And unfortunately, it is not like NHS that, you know, you are registered there, you will only go there. So in India, they are here and they just finally decide to reach. But, you know, the technology, I think the random stimulation is very good. We have got results. And also the vitrification has become very good. So I think there are some advances in these side that we don't have to actually just wait for the fresh ones. But yes, this can be used, and I personally used it and I found good pregnancy, because I used to be scared. I don't know what I'm doing. Still, it's not a standard protocol. It is, I don't know whether Dr. Anil Gudi is listening or not, but it is probably still not is a standard way of treating. What about Dr. Shantanu? What do you suggest? Do you think it has become a standard still?
No, I'm afraid I don't think it's standard yet. We would, no, because still with ANTAG or a flare protocol, we wouldn't be kind of losing a lot of days. Many of our patients, if the private center, if they're coming from abroad, we would usually liaise with the team, and over there they can get their ANTAG started, and therefore it doesn't actually add any time.
Yeah.
So therefore for us, it doesn't make any significant difference. Maybe in London, for example, many people come from abroad, from the Middle East and others, where they have very short time. But for Glasgow, no, it's not probably.
But I think good scanning and, sort of individualizing each case is, of course, where the, expertise is. And I think that is what
Can I just add, Puneet, you did say that in random stimulation, there will be less number of eggs. But, in Dr. Gudi, what he said, you have a bigger pool, and you can chase the follicles, and you can have a higher number of eggs at random stimulation, and you can also have double stimulation in that. So anyway, it's all, I know it's not a standard of care at the moment. So we have to wait and see.
Yeah, we have to wait. We still need larger trials.
Yeah.
But one thing is very important, I think, scanning yourself and looking into those finer details, which he has just mentioned in his talk, will, probably will be helpful for all of us. Ma'am, should we, I think it's time to close the session. And Dr. I think Nirmala was not able to join us. She has sent her apologies. So, but you want to close the session, or?
Yeah, so I really thank Anjila, you are here. So thank you very much for coming and honoring us. 2-3 presidents of different societies, like Anjila from Delhi, and then Sarita Bhalerao from Mumbai Society, and now Anjila from DGFS. So lots of, and then Shantanu, of course, from, you are in Dublin, are you?
Glasgow.
Glasgow. All right. You're in Glasgow. All right. So many stalwarts, and our own people, like, very good orators like Jyoti, Puneet, and Nikita, Nima, Harbinder, all were there. So it really made a difference. And thank you very much, all of you, to all the chairpersons, and their contribution and their add-ons were really very helpful. Thank you very much.
Ranjana, for calling me. So I'm not an infertility person, and I don't know if it's standard or not, but Dr. Gudi's talk was very good, very simplistic. I really enjoyed it. Maybe it will become standard, and the panel discussion was, of course, very good. And
absolutely.
And Anjila, the thing is, we need to know. We are not infertility specialists, but we need to know. Then we will try, refer patients to these people, right? if we are not aware of it, so that's how they have to teach us.
Egg freezing also broadened my perspective about egg freezing.
Of course.
For me, it was 2-3 things, and now I've learned. There's so many nuances to it. So thank you, Sweta, and thank you, Ranjana.
Shweta, well done.
Thank you.
Very good. Shelly, did a good job, all of you. Thank you very much. And Sweta, we need to involve non-infertility people in the group. Then, because people come to us, they don't know that we are not the right people. But how to channelize them? If we don't know, you don't get them, right? Thank you.
Thank you. Thank you, ma'am. Thank you, Dr. Anjila, Dr. Angela, everyone, and Dr. Deepika also for helping us out. Of course, we had actually shifted from the 2nd to 6th, and she always helped us.
Yeah, Deepika has become like our family.
Yeah.
She's an RCOG family. She
Thank
was
you very
everywhere.
much.
Even in the
He's family of all societies.
So, ma'am, I'll take this opportunity and thank everybody on behalf of Jackson Pal. Jackson Pal brings to you Lycorate soft gels to manage the oxidative stress during fertility treatment. Also, sugar-free Lycorate Preg sachet in orange flavor, L-arginine, lycopene, and DHA to prevent pregnancy complications. JP-tone iron syrup with zinc and vitamin B helps you say no to anemia. And natural micronized progesterone sustained release oral tablets as DivaGest SR 200 and DivaGest SR 300. So my teammates, Dr. Vipin Tyagi and Mr. Amit Saxena joined me to thank all the respected faculty and all the attendees present with us today. And we hope to see you again tomorrow at 5 p.m. That is Healing the Healers and Humanity with Swami Shailendra Saraswati and BK Dr. Mohit Gupta from GB Pant Hospital. Please note down the Zoom ID in case you are interested to join in. Thank you so much. Stay safe and thank you very much, RCOG. Bye-bye.